friends, we'll be discussing anatomy and evaluation of brachial plexus injury in this chapter. The management of brachial plexus injury will be discussed in a separate chapter. I am Dr. Nishchal Naik, who will be speaking on this topic. Brachial plexus injury was first described in 800 BC in the Iliad by Homer. As it described, Hector sprang from his chariot to the ground seizing great stone, and when he hit him where the collarbone is, and his hand lied like a dead hand. Leonardo da Vinci was the first person to describe anatomy of human body in extensive detail. He had carried out dissection of human bodies. He started it in 1507. The first one was a 100-year-old male who had died of natural causes, and his description was entitled as the Old Man. And he was the first person who said that the nerves were the things that control the muscles and sensations, and nerves are the captains of the whole ship. The first description of modern nerve repair dates back to 1824, where the superior end of one nerve was repaired with inferior end of the other, and vice versa. The first brachial plexus reconstruction dates to 1948 in Moscow, USSR, where a 20-year-old female injured by a bomb fragment was operated. It was now transfers were done with long thoracic to suprascapular, pectoralis to musculocutaneous, and two triceps branch to axillary nerve. Why it is important is before its results. You can see for yourself that the results that they had got for elbow flexion, shoulder abduction were reasonably good. Describing the anatomy, best way to remember is that real athletic trainers drink cold beer, which means R is for the roots, T is for the trunks, D is for the divisions, C for the cords, and B for the branches. And this is how you can see the brachial plexus in diagrams. The important nerves in brachial plexus that you have to remember is suprascapular, musculocutaneous, axillary, median nerve, and lateral pectoral nerve. From the roots, you can see there are two branches. One is dorsal scapular and another is phrenic nerve, which curves around the scalenus anticus muscle. From the trunk, you get two branches. One is suprascapular nerve, which is one of the most important nerve in brachial plexus repair. Another is nerve to subclavius. Coming to lateral cord, there are three branches. One is lateral pectoral nerve, another is musculocutaneous nerve, and the lateral half of the median nerve, which is mostly sensory. From the posterior cord, you remember it as ultra, upper suprascapular, thoracodorsal, lower suprascapular, the radial nerve, and the axillary nerve. It lies posterior to the axillary artery. From the median cord, there are five branches: medial pectoral, medial cutaneous nerve of arm, forearm, the lateral half of the median nerve, or it's a medial half of the lateral median nerve, and the ulnar nerve. How to draw brachial plexus is very important, especially these things we are taught in MBBS. In first MBBS, this is the easiest way to draw a brachial plexus. Draw two headless arrows, then add an headless arrow in opposite direction, add an W to the previous two arrows, add an X and a Y branch, label them as C5 to T1, label the major branches of W and the reverse arrow. Then draw three branches on upper part which will be dorsal scapular, suprascapular and lateral pectoral. From the middle or the posterior tongue, draw the 3 branches, label it as it is. Draw 3 branches to the medial cord and divide it into root, tongues, divisions, cords and terminal branches. And that is one extra branch, that is now to subclavius, that has to be added. And that is a complete diagram of the brachial plexus as we get it. Evaluation of brachial plexus injury. Most important is clinical examination of the patient. You have to look for movement, the motor examination, reflexes, the tone of the muscles, wasting of the muscles most of the times when it is present, the sensations which are equally important. Radiography has to be checked. What is important is X-rays, MRI, CT scan. CT myelography is more important than plain CT scan. Electromyography and nerve conduction study has to be done. Radiological examination in detail, if we discuss, angiograms are very important. CT angiography could be done. Diaphragm can be assessed, especially in case of phrenic nerve palsy, whenever there is T3, 4, 5 avulsion injury. Exploration and intraoperative electrodiagnosis is also important, and intraoperative electrodiagnostic management is also done in case of brachial plexus injury. As you can see, these are the clinical signs: the hollowness or the wasting of muscles and lack of movements. Thank you.